I know, I can hear it.
Hello. Okay, we are live. So I won't be able to tell how many are connected, but we might wait a minute or two while I decide what I'm going to do with this child. Okay. Hi. Hi, Zyla. Yeah, Daddy's doing a webinar. Okay.
Very appropriate during a paediatric dentistry talk to have a child in the
It is.
background. So it sounds good.
Very appropriate. Yeah, absolutely.
On brand. It's on brand.
We're on brand. Okay. If anyone is out there, can you write a comment so we know that you are there? Anyone is out there? Yeah. Okay. We got some people. Yay. Hi, everybody. We got a few highs. Okay. We're just working this new system, people. I wonder if Alyssa can you see those comments as well on the side?
No.
It's a lot of highs.
Okay. Hello, everyone.
Okay, so I guess we're ready to start here. A lot of familiar faces. Good to see you all. So welcome to the General Dental Residency free webinar series for 2024. It's a series of, I guess, webinars on topics that are hotly debated in the world, or maybe are a point of confusion for some people. So we are starting with pediatric dentistry. So for the majority of you who are here, you are seeing children, whether you are a dentist or you are a OHT. And, children are a big part of our practice, and you will obviously see a lot of kids with decay, caries, and I guess we want to know what's the best way to go about treating these things. So we've asked Dr. Alyssa Brooks to come in, and she's graciously accepted the invite. So a little bit about Alyssa. I'm just going to so Dr. Alyssa Brooks here. Sorry, Alyssa, just give me a second here. She's a pediatric specialist dentist who works in Melbourne's West. Born and raised in Melbourne, she completed undergraduate dental training at the University of Melbourne. Upon graduating, her interest in the management of pre-cooperative and behaviourally challenging children inspired Alyssa to return to the University of Melbourne to complete postgraduate specialist training in paediatric dentistry. Alyssa enjoys sharing her knowledge and passion for pediatric dentistry and advocating for children's dental health. She is the current president of the Australian New Zealand Society for Paediatric Dentistry Victorian branch. So thank you so much for coming along, and I'll leave it with you, Alyssa.
Fantastic. Thank you so much, James, for the kind introduction. And thank you very much for the invitation to speak tonight. So today, everyone, I aim to provide you all with some tips and tricks for the successful management of your pediatric dental patients, and we're going to focus on choosing restorative materials in the primary posterior dentition. So today, I'm going to cover choosing the right restorative material for the right situation in the right pediatric patient. I'm going to focus on the restoration of the primary posterior dentition today. After a brief discussion of caries removal theory, I will cover the indications and contraindications for the most common restorative materials that are available to us. I'm also going to talk about how to help our paediatric patients get through their restorative appointment with some behavioural management tips and tricks. So today I'm going to cover, my apologies. So regarding the management of carious lesions, I'm going to recommend this paper. It was a consensus paper written by the International Carious Consensus Collaboration. I would recommend it as a good read to brush up on recent advances in caries management. So this paper recommends that we avoid entering a tooth into the restorative cycle for as long as we possibly can. Therefore, biofilm removal should be the method of choice until a lesion cavitates, and then it makes the area non-cleansable, and that is when we have to intervene restoratively. So once we deem from our clinical decision that a restoration is required, we then need to assess caries depth. In a shallow to moderate caries lesion, we can remove caries to hard dentine. Hard dentine is defined as dentine that can only be removed with a burr. This allows a tight seal and placement of a durable restoration. Whereas in deep lesions, the recommendation is selective removal of carious tissue near the pulp to soft dentine. So soft dentine is defined as dentine that will deform when a hard instrument is pressed onto it, and it can easily be scooped out with a sharp hand excavator. Soft carious tissue is left over the pulp, and this avoids exposure and stress to the pulp, therefore promoting pulpal health. Always remember that in primary teeth, we have another tool to treat deep lesions, and that's we can do a pulpotomy procedure. When we look to both the American and European Academies of Paediatric Dentistry, both academies recommend against complete caries removal in the primary dentition in deep caries lesions. The AAPD recommends that incomplete caries removal should be considered in primary teeth with deep caries and normal pulp status or reversible pulpitis, when complete caries removal is likely to result in a pulp exposure. Similarly, the EAPD gives a strong clinical recommendation for selective caries removal as an effective treatment modality for the management of deep caries in primary teeth. They recommend that we use the least invasive technique for the most predictable clinical outcome, and they unanimously agree that a good coronal seal is essential for the management of a vital pulp. So to recap, when we think that a restoration is indicated, our priorities are to maintain pulpal health, preserve healthy and remineralizable tissue, achieve a restorative seal, and maximize restoration success. Now, depending on the depth of the lesion, this will depend on what we should put the priorities in which order. So if we have a deep lesion, then maintaining pulpal health is going to be at the top of the list. However, if we have a more shallow lesion, then getting that tight restorative seal is going to be more important. So basically, we just want to create the best possible environment for the restoration to be durable, but also to ensure that the pulp is still nice and healthy. So there are a number of factors to consider when we choose which restorative material. For the purpose of our discussion tonight, I'm going to focus on the restorative materials that we use most commonly in everyday practice. So we have glass ionomer cement, resin composite, stainless steel crowns using the conventional technique, and then also using the Hall technique. And as I mentioned before, I'm only discussing the primary and posterior dentition tonight. It's important to note that primary enamel has a different composition to permanent enamel, with a more pronounced prismless layer. Due to the difference in structure, it has been postulated that the bond strength of composite resin to primary enamel is less than to permanent enamel. It's also important to note that in the primary dentition, we have to consider the time until the tooth exfoliates. For a younger child, we need this restoration to last for a long time. But in an older child, the restoration durability is really less critical. Wong and colleagues in 1989 found that the age of a child at the time of treatment affected the lifespan of the restoration placed. And Espelid and colleagues in 1999 discovered that this was more pronounced if the child was under 5. There are also a number of patient factors to consider. In general, the more surfaces that are affected, the larger the lesion, the deeper the lesion, and the higher the patient's caries risk, the more likely that we should choose an indirect restorative material. This improves restoration durability and retention. And basically what we aim to do is avoid the need for retreatment prior to the tooth exfoliation. It's also worth noting that direct materials appear to be less durable in proximal restorations rather than in occlusal cavities. A final consideration is compliance. How long is our paediatric patient going to stay still? Are they going to tolerate adequate moisture control? Are they going to tolerate local anesthetic? Sometimes what looks like the best restorative material on paper is ruled out because of patient compliance. So let's start our discussion with GIC. All glass ionomers have several properties that make them favorable for use in children. These include things like chemical bonding to enamel and dentine, thermal expansion similar to that of tooth structure, they're biocompatible, they take up and release fluoride, and they have decreased moisture sensitivity when we compare them to resin composite. So the uptake and release of fluoride make GIC particularly useful in caries stabilization in high caries risk patients. They act as a reservoir for fluoride, and they can take this fluoride up from toothpaste, mouth rinses, and topical fluoride applications. GIC is best used in occlusal rather than proximal cavities as they have limited mechanical strength, and this means that they are more likely to fail in stress-bearing cavities. Multiple systematic reviews and meta-analyses have found low longevity for conventional GIC in proximal restorations, and therefore its use is discouraged when we restore those proximal lesions. A systematic review by Chadwick and Evans found failure rates for proximal restorations was as high as 60% when we used conventional GIC. And then it was still not a great, but better result of 24% for RMGIC. And they found that the failure rate increased the longer that they watched these restorations. We should note, but, that if we are using RMGIC, it has a resin component. So this makes moisture control much more important than if we're using a conventional GIC. So my personal recommendation of when I use GIC is I'll often use a resin-modified GIC in a small occlusal cavity in a patient who has some cooperation but not heaps of cooperation. So maybe like a small occlusal cavity that's just into dentine, and I think the child will tolerate having cotton rolls in place. We hopefully won't have to use local anesthetic, and we can get that small lesion restored for them. So another way we can use GIC is using the atraumatic restorative technique. It was initially designed for use to combat severe early childhood caries in developing countries, but now it's also used in oral healthcare systems all around the world. It involves the removal of the soft caries tooth structure with a sharp spoon excavator, and then placement of a conventional GIC over the top, and then also as a fissure sealant into the remaining pit and fissure system. A systematic review found 94% success for single surface restorations over a 2-year period. However, multi-surface restorations are much less successful, with a 17% failure rate over a 3-year period. Interestingly, you can use this technique with silver diamine fluoride, and this is often known as SMART. And if you apply some silver diamine fluoride before you put your GIC on, it's been found that it has no negative effect on the bond strength between GIC and dentine. So an atraumatic restorative technique can be quite useful in caries stabilization in young children. The next material we'll talk about is resin composite. So resin composite can be used in occlusal and small proximal cavities. It has greater mechanical strength than GIC, so you can comfortably use it in smaller proximal cavities that do not extend beyond the proximal line angles. The main contraindication for resin composite is inadequate moisture control. So we've got to remember that the enamel in primary teeth is less conducive to bonding. So poor moisture control is really going to detrimentally affect how long our restoration will last. I routinely use rubber dam when I'm placing resin composite restorations, which I find is actually well tolerated in compliant children, and it helps to prevent them from closing halfway through a restoration being placed or licking the restoration halfway through it being placed. So I find that it really helps a lot. We should also consider that if bonding is unpredictable, then a larger multi-surface lesion is probably not going to be well serviced by resin composite, and we should probably consider using an indirect restoration. In high caries risk patients, the potential for secondary caries underneath the base of a proximal restoration should be considered. So you have to think about, is my child going to floss? If a high-risk child is not going to learn how to floss or is not able to learn how to floss, then maybe a stainless steel crown that covers the entire proximal surface would be a better restorative choice. So again, my personal recommendation is maybe we use resin composite in a small proximal cavity in an older child where I can use rubber dam and the child is likely to be able to floss, or the parents are really motivated and they're going to floss that child's teeth. To recap, this adapted figure from the AAPD guidelines shows their recommendations. So in an occlusal cavity, they recommend the use of composite, conventional GIC, and RMGIC. However, in a class 2 or proximal cavity, they don't recommend conventional GIC, and there's actually stronger evidence to use resin composite over resin modified GIC. So now if we move on to the indirect methods, let's start with the gold standard of the conventional stainless steel crown technique. So stainless steel crowns have been found to be superior in durability and longevity to class 2 direct restorations in primary teeth. They've also been found to have superior longevity compared to direct restorations following pulp therapy. So in a high caries risk patient, as I mentioned before, full coverage prevents another tooth surface from breaking down or from getting secondary caries under the base of the restoration. And this makes stainless steel crowns ideal in these situations. A Cochrane review of stainless steel crowns concluded that they have few indications, they have few contraindications, mainly just allergy, like a nickel allergy, or maybe if the tooth is close to exfoliation. So if the tooth is close to exfoliation, we may consider that a less durable and potentially less costly restoration might work for the time needed before the tooth exfoliates. So in my clinical practice, I place a lot of stainless steel crowns with the conventional technique, and I tend to place them on multi-surface or pulp-treated primary teeth in a compliant child. And then I also do a lot of work under general anesthetic. So at a general anesthetic, a stainless steel crown is often my material of choice. In terms of how we complete a conventional stainless steel crown, once we've removed the carious tissue, then we're going to reduce the occlusal surface by about 1 millimeter to 1.5 millimeters, and this allows for occlusal clearance. Next, we're going to do the proximal surfaces, and basically you just slice through these with a thin tapered burr, and you want a feather edge with no steps or ledges. No preparation is usually required for the buccal or for the lingual surfaces. You might just need to round off the corners where the buccal and lingual surface meet the occlusal surface. Following that, you should try the stainless steel crown in. If you haven't placed many stainless steel crowns, I usually recommend starting at a D4 and an E3 because a lot of teeth are this side, and then you can work your way up or work your way down. Always try to fit the smallest crown possible. So if you're not sure, then try one smaller and see if it fits. To check for fit, you can compare the occlusal table with the adjacent tooth. If it matches, then you've probably got it on straight. To cement it, fill the crown with GIC luting cement, then roll the crown from the lingual surface to the buccal surface. You need firm pressure to seat the crown. So often I'll have the child bite down on a cotton roll, and that means that they've pushed it down enough. You can remove cement with gauze, definitely with floss for the interproximal surfaces, and then also some triplex water spray. If we now consider the Hall technique, the indications and contraindications are similar to the conventional technique. Given that the Hall technique requires minimal cooperation, it's really useful in younger, less cooperative children. Despite this, the Hall technique has remained really controversial in the paediatric dentistry sphere, But now there's over more than 10 years of literature to support its use. The main thing about Hall technique is case selection. You need to have the right case, and this is essential for success. So there are 2 requirements that you need before you place a Hall crown, and that is to make sure that you have a pre-treatment radiograph. A pre-treatment radiograph is going to help you determine whether or not you have a sufficient amount of dentine between the pulp and the caries tissue. The recommendation is that there should be a distinct band of dentine between the deepest part of the caries lesion and the dental pulp. The pre-treatment radiograph basically makes sure that you're not putting a crown over a pulp-involved tooth. Nicola Inez, who is the modern champion of the Hall technique, found in a retrospective analysis of 161 children who attended the Dundee Dental Hospital in Scotland that when the clear band of dentine was present and was used as an indication for case selection, there was over a 97% chance of success in treatment when they followed these children for 3 years. Also, I've often used the ability to tolerate a bite wing radiograph as an indication of how the child is going to cope with separation placement and cementation. You have to remember that you need a child who has some cooperation to be able to put a Hall crown on. They need to have a little bit of tolerance to being uncomfortable. So often a bite wing can be a good way to see whether or not they can tolerate things in their mouth and that sort of thing. The advantages of the Hall crown is that mainly that it's minimally invasive and it's well tolerated by children. So this in turn often makes dental practitioners feel more confident in using the technique. Randomized control trials in both Scotland and New Zealand have found Hall crowns to have a much greater longevity over a 5-year and a 2-year period, respectively. And when they compared this to the conventional GIC that was most commonly used in general dental practice. And as we talked about, conventional GIC, based on a whole bunch of studies, is no longer recommended for proximal surfaces. A disadvantage of the Hall technique is that you're not actually removing any caries. A Hall crown works by basically depriving the lesion of fuel, and it makes the environment unfavorable for caries progression. The dental pulp will lay down reparative dentine, and this effectively means that the pulp is retreating away from the carious lesion advance. So provided that we've picked the right case and there is that band of dentine between the pulp and the carious lesion, then while the pulp is laying down reparative dentine, the caries advancing front shouldn't hit that pulp. So yeah, we need to take an x-ray to make sure that we're not putting a crown over a pulp-involved tooth. Finally, Hall crowns, when we place them, you're going to end up with an increased vertical dimension of occlusion. However, this has been shown to equilibrate after about 30 days. So as long as we don't terribly seat them incorrectly, small increases in the vertical dimension are not usually uncomfortable to children. So if we look at these 2 pictures, on the right-hand side, on tooth 8-5, we've got a moderate-sized caries lesion that was actually on a kid who had hypermin, and the hypermineralization had undergone some caries breakdown. Now, on that tooth, we can see that there's a distinct band of dentine between where the caries is and where the pulp is. So this tooth would have been appropriate for a placement of a Hall crown. On the left-hand side, if we look at tooth 8-4, we can see that there's quite a large caries lesion, and the caries lesion is approximating the pulp. There's not really that clear band of dentine that we're supposed to be looking for. So this tooth did end up having a pulpotomy because once the caries tissue was removed, we had a caries exposure of the pulp. Now, in this set of pictures, I've got some radiographs of teeth that have been treated with Hall crowns. So if we focus on the picture on the right to start with, in the lower arch on teeth 7, 4, 7, 5, we've got some well-seated hall crowns. There is minimal overhang, and they're in line with the occlusion of the neighbouring teeth. When we look at the tooth 6, 4, so that's also had a hall crown. When you look at it, it doesn't look that bad. It's covering most of the tooth. But if you look a bit closer, you can see that it's actually quite high compared to tooth 6, 5. And clinically, you could actually see a large proportion of the palatal surface. So I think what had happened was they had tried to seat the tooth from buccal to lingual, hadn't quite got it down, lost compliance, and then the cement had set. And then they were kind of like, near enough is good enough. And then this child later presented to me. In this same child, when we look at the picture on the left-hand side, on tooth 5, 4, unfortunately, this tooth was also having an ill-fitting stainless steel crown that hadn't been properly cemented. But unfortunately, there had been secondary caries. This secondary caries was subgingival, and unfortunately, this tooth had to be removed. So how do we place a Hall Technique stainless steel crown? Basically, we're going to put some elastomer separators, floss them through the contact points or points, depending on which tooth you do. And what you want is the top part of the separator to be visible above the occlusal surface. Then ideally, you remove this after a few days at a cementation appointment. If you leave it in too long, so let's say you get back to this kid in 2 weeks, it'll probably have fallen out. And if you do it too quickly, you might find that you haven't created the space that you wanted to help with the crown cementation. So ideally a couple of days, at a pinch, do it in the morning and then get them back in the afternoon. If the separator falls out a day or two before their appointment, you're probably fine. If it falls out much before their appointment, then you're going to have to get them back in to put the separator back in. Then when you're thinking about how to fit the stainless steel crown, you should aim to fit the smallest size crown that will seat. So you want to select one that covers all of the cusps and approaches the contact point, and then when you push on it, it has a feeling of what they call spring back. You don't want to push the crown completely on before you've got the cement in there, because sometimes it can be very difficult to remove, and then you've lost the patient's compliance as you're trying to get this crown off. As I said before, with crowns, if you're in doubt, try a smaller size. It's quite common for us to put a larger size than needed on. And then you have troubles with overhang and food getting stuck around the margins and that sort of thing. So now we're thinking about cementation. So to cement, you want to place the crown over the tooth and seat it with your finger pressure, or by getting the patient to bite down on the crown, maybe with some cotton roll-in like I described earlier. Or often I'll use a combination of both. So I'll get it down as far as I can with my finger, and then I'll get the patient to bite down on a cotton roll. And often I'll say something like, bite down like you're really angry at your mum or whoever brought to the appointment, or some people say, bite down like a grizzly bear and grr. There's many ways that you can kind of tell them how to do this. It's important to ensure that you've got the crown fully seated, because once the cement's set, it can be very hard to take these off. Now you're introducing water spray, you're introducing high-speed suction, the child is going to have to stay still for longer. So all of these things mean that a compliant child turns into a non-compliant child if you push them too far. So to make things easier, you should always avoid fitting adjacent hall crowns, because it's rare that you've created enough space for 2 crowns when you've put one elastic separator in. So better off to do one and then come back and do the other one. You should also avoid fitting opposing hall crowns. So let's say a 5-5 and an 8-5. Because the exaggerated increase in vertical dimension is likely to be uncomfortable to a child. However, you could do the 5-5 and the 7-5, and then that would basically even out that increase in vertical dimension. So now we've decided what restorative materials we're going to choose. How are we going to convince this child to proceed with treatment? So on this slide, I've basically just listed a whole bunch of behavior management techniques, and they can be used in many ways. You can use them together in multiple successful combinations. At the bottom of the slide, I've also got some good references if you want to brush up on your familiarity with any of these techniques. Those highlighted in red are the more assertive management methods, and these have fallen out of favor and are not as recommended these days. It's important to note too that these techniques are not a rule book for managing dentally challenging children. It's important that you have a wide range of behavior guidance techniques to meet the needs of the individual child. Often, management strategies are most effective when they're honest extensions of your own personality. So some techniques will work better for you than they will for someone else. Another thing that you have to remember is that behavior management is not manipulation. You might need to bend the truth, you might need to dress up the truth, but when you're managing pediatric patients, children dislike dishonesty. So when they feel that you are not being honest, you can lose their trust very quickly. So it's important to discuss treatment honestly, but in child-friendly terms, and that way you'll earn their trust. So here I've got a list of euphemisms that I often use when I'm treating pediatric patients. And I'm sure you all have your own that you use, and some of these might be new and useful to you, so you're welcome to use them. But you've got to make sure that the words that you use are appropriate to the age group that you are treating. And as I said before, it's always best if the words that you use and the behavior management that you use is an honest extension of your own personality. So you pick the words that feel most right to you. So how do we manage a fearful pediatric patient when it comes to the restorative appointment? While dental fear may be considered a normal emotional response to what is perceived as threatening stimuli in a dental situation, dental anxiety goes a step further because it's not only that dental fear, but it's also a sense of losing control. So it's important to try and figure out what is making that child fearful. For a younger child, it might be something simple like sitting in the chair by themselves. A lot of 3 to 4-year-olds are actually very compliant once they're sitting on their mum's lap. They just need that security blanket. And then for an older child, it might be that they've heard about dentistry from their friends. Maybe they've heard that they're going to get a needle at a restorative appointment, and then that's where they have that fear. So you can make them feel more comfortable if you target the specific thing that they fear, if you know what it is. Once the etiology of their dental fear has been determined, the next part of management involves determining the child's coping mechanism. There is evidence in the literature that there are individual differences in the extent to which patients want to know what's happening in an anxiety-provoking medical or dental procedure. So Miller in 1987, he proposed the concept of monitors. These people want more information so that they feel more in control, and blunters, who basically want to avoid knowing what's happening and they want distraction so they don't know what's happening. And an individual can actually be a combination of high and low in both of these cognitive coping styles. So you can get a sense of a child's coping strategy through discussion with the parent and with the child. You can ask them how they've coped with similar medical procedures like medical examinations, immunizations, blood tests, hospital visits, and that can sometimes give you an insight into how they're going to fare for dental treatment. If you know how a child copes with fear, then you can use that to tailor your behavior management. So a monitor is probably going to like tell, show, do, knowing every single step and what's going to happen and what's expected of them at every single step. Whereas a blunter is probably going to like distraction. So things like watching TV or listening to music during a procedure. Another behavioral strategy useful in management of fearful patients is establishing rapport. So you've got to be openly communicating with the child at a level that they will understand. You've got to remember that you're not just establishing rapport with their parent, you also have to establish rapport with the child. And that's really, really important. So if you can establish rapport with a child during an examination, then they will have that trust in you when you get to something more tricky like a restorative appointment. During a restorative appointment, one of the things that I use often is positive voice control. So voice control describes the deliberate alteration of voice volume, tone, or pace to influence and direct the patient's behavior. So an example of positive voice control is a soothing statement like, "Johnny, take a nice deep breath through your nose, all the way down to your belly, and then breathe it out through your mouth." So things like that, putting the child into a trance-like state, basically with your voice, can help to make them feel soothed. Another thing that I use often is a stop signal. So this gives them a sense of control over what's happening in the dental procedure. So basically put your hand up if you're uncomfortable, or put your hand up when you want to have a break or something like that. You've got to be careful, bud, because sometimes kids will abuse that stop signal and you'll have to stop all the time. So if I'm getting the sense that that's the way it's going, often I will use counting. Counting works the same way. It gives them a sense of control so that they know that something is going to stop at some point and then they can have a break. If your child is very annoying and says you can only count to 5 instead of 10 or something like that, you can get a bit of wiggle room by saying, okay, I'll count a little bit slower. So the slower you count, the more time you have to get through what you need to do. So now we're going to think about, how do we give LA? When I'm giving LA, which is often required in a restorative procedure, I very, very, very rarely use the word needle. Most of the time in children, especially younger children, it just doesn't help. They have a preconceived idea of what a needle is, and to them it's the most scary thing ever. So most of the time I tell them I'm going to put some topical anesthetic on. And then I tell them I'm going to rub in this sleepy cream, and I just rub it in like sunscreen. This is what it looks like. I show them that part. And I tell them, just going to rub it in. And then I say, oh, I'm really sorry, this tastes yucky. Oh, did you get some on your tongue? Okay, we'll give it a good wash. And then I tell them, all right, so next we're going to put some sleepy juice in. And I say, look, I'm really sorry, this one tastes extra yucky. Maybe you can close your teeth so you don't get it on your tongue. Often when they bite down, then their lips are easy to manipulate, and then also you're not dealing with a child who's moving their mouth open and closed as you're trying to give the local anesthetic, so it just makes them a little bit more stable. And then I say, oh, close your mouth, because this bit's going to taste really, really yucky. And then I'll tell them something like, okay, so you might feel some pins and needles as it starts to work. And most of the time, that's enough information for them to know what's happening and also be none the wiser that we've actually done the needle part. So let's finish off by talking about some clinical cases. So in this case, we've got caries on the 6-4 distal, the 6-5 mesial, the 7-4 distal, and the 7-5 mesial. So the question is, what would you do? So let's look at the upper arch first. So on 6-4 and 6-5, they're pretty small lesions, so a direct restoration would be appropriate. Then on the lower arch, we've got some deeper lesions, but there is a distinct band of dentine between the lesion and the pulp. So in this child, I did resin composite restorations for the 6-4, 6-5, and I did sand steel crowns for the 7-4, 7-5 using the conventional technique. I was able to have adequate moisture control because I had rubber dam, and the parent was going to help the child floss. In the lower arch, because I had the compliance for local anesthetic, it wasn't an issue to use the conventional technique. But on the flip side, you probably could have done a Hall crown for those lower teeth if you needed. If we look at this second case, there is a very small lesion on the 6-4 distal, and there is a much larger lesion on the 7-4 distal. So this child was actually managed under a general anesthetic. Because I was under that general anesthetic, I decided to restore the 6-4 distal. if you were treating this child in the chair, you may consider that you want to monitor this tooth to see whether or not there is caries progression. But seeing as we were under general anaesthetic, high caries risk child, trying to avoid the need for retreatment and the need for a subsequent general anaesthetic, I decided to restore the 6-4, and we did that with resin composite. In the bottom arch, so 7-4 distal, you can see quite a deep caries lesion, and there's not really a distinct band of where the caries lesion ends and where the pulp starts. So on this tooth, I removed caries, and yep, we had a caries pulp exposure. So this tooth ended up having a pulpotomy procedure and then a stainless steel crown. So that was everything I had to share today. I am more than happy to take some questions.
Hi, sorry. Thank you so much, Dr. Alyssa. Very informative, and I'm sure a lot of people have learned a lot from just a very small insight into the world of pediatric dentistry here. And yes, we do have some questions here, so we'll go through them. But before we go through them, I'm going to, if for those who are interested, we do have other events with GDR. So I'm going to do a little quick plug, and then we'll go over the questions. So I'll just bring up my my little bit here. So we've got, for the dentists in the crowd here, we have a annual dental residency. We have 2 or 3 cohorts a year, and this goes over 5 live weekends, and we have 12 months of mentorship. And if you sign up before the end of this month, pretty much, you just message me if you need a special extension. You'll get a free bonus worth over $2,000, which includes a study club ticket, which we'll go over in a moment, and a restorative kit, and some access to some camera photography modules. It's highly recommended if you're an early or beginner dentist who wants to just upskill themselves. We also have a OHT residency that is launching in July. So these are for those who want to increase their treatment planning. We find that a lot of new OHTs have a bit of trouble just mastering talking to patients about these things. So we will go over hands-on as well. So we have communications, photography, one weekend, and a second weekend, 3 days, where we go through stainless steel crowns, we do direct restorative methods, and a bit of orthodontics as well with the clear aligners and fixed, just practicing banding up and all that. You'll also have 2 treatment planning sessions, 3 with Alex and myself, and you'll also have access to online content with lectures and pre-recorded material. So that's, if you are interested, you can ask your boss if they want to shout you. That'll be lovely. We also have finally a in-person study club coming up in Melbourne on May the 26th. So we have 3 speakers, including Dr. Alyssa Brooks here. So each speaker, it's more like a multidisciplinary session here. So each speaker will have about an hour, just over an hour to speak, or an hour and a half, on a topic of their liking. So we've got Dr. Alyssa with Paediatric dentistry. We've got Dr. Alex Kaminsky talking about perio, and we've got Dr. Raina Yang, a Melbourne-based dentist, talking about restorative. And this is a study club directed towards our OHT audience. So it's not going to be advanced implants or things like that. So you're more than welcome to come along to that. We will launch more details later this week or next week. So keep your eyes peeled for that. So we'll go over the questions and answers now. Let's see here. So we've got Carla here. Do you have any tips for rubber dam placement in younger children?
That is a good question. So the first thing I would do is make them numb. when I was training, I had rubber dam placed on when I was not numb by an endodontist, and it hurt a lot. So make sure they're numb is step one. Next thing is I use all of that kind of tell, show, do. So we're going to put a raincoat on your tooth. We put some little holes in the raincoat. See, here are the holes. So now to get the raincoat to sit on, we're going to put a button on your tooth. Yep, this is the button. We put that on with the rubber dam faucets. And then we're going to say, okay, so we put the raincoat over the button, and it's going to make a couple of clicky noises as it goes on. And then we've got this little coat hanger, and that's going to hold the raincoat in place. Make sure you don't get their gums when you put the clamp on. But yeah, a lot of the time that kind of tell, show, do, telling them each step as you go helps. And finally, make sure they can breathe. So make sure that you're not covering their nose. Usually you can do some little tricks of kind of folding the dam in a way that they can make sure that they breathe through their nose. I hope that answers the question.
Lovely. Okay, we've got Amber's question. I think that's been answered already about adjacent SSCs. Okay, we've got Jessie here. Alyssa, do you have any tips on seating SSCs in situations where they've been space loss due to decay?
That's also a very good question. So I didn't cover this, but you can crimp a crown. So hopefully you have access to crimpers. And basically what I do is I use the crimper to squish the proximal surfaces so they're a little bit narrower, and then that lets you put it on. That other person was talking about adjacent stainless steel crowns. If you've got space loss and adjacent stainless steel crowns, it can be really hard to seat them. Often I will put a wedge in and then come back to it. So find something else to do and then come back to it so that you've created that same interproximal space, kind of like using an elastomeric separator. So I suppose if you know that you're going to put a crown on and you can put a separator in before the appointment, that's going to make your life a lot easier.
Awesome. Next is we've got May's question. What type of cement would you place for a stainless steel crown?
So you can use a GIC luting cement. So often I'll use a Fujisem or a Meron. You can use Fuji 7. I wouldn't use Fuji 9. And I wouldn't use an RMGIC just because there's no real point in having the resin modified aspect to a luting cement.
I learned something new as well. There you go. Next question's from Sikai Sun. Hi, Alyssa. If teeth develop pulpitis after stainless steel crown placement, what would you do?
Mm-hmm. So you've got to think about, why did you put the stainless steel crown in the first place? Was that the correct treatment at the right time? If the tooth develops a pulpitis after stainless steel crown placement, presumably this tooth actually had pulp involvement. And maybe before we put the stainless steel crown, we should have done a pulpotomy procedure. Unfortunately, a lot of the time after the tooth gets the pulpitis, it's a downward spiral from there. You could try take the crown off and do a pulpotomy, but there's a good chance that you'd clean it out and then you'd find that actually the tooth is hyperemic and you might end up having to take the tooth out. So I suppose the answer is, make sure that you do the right thing to start with. Don't be scared of doing a pulpotomy if you think the tooth needs it.
Awesome. That's right. Don't be scared. Next up, we've got May again. If you like to do a block for a case 1 SSC on the tooth 7475, if so, do you have tricks on giving a block in a child? This is also a really good question. I 99% of the time will not give a block. I don't give blocks to children. The reason for that is that infiltration works. In your adult patients, you might use an infiltration for treating like a 3-4, 3-5 if you had a composite restoration or something like that. You can do an infiltration for children. The other thing is, I routinely use articaine. The reason why I use articaine is that I know it's going to work. And you might only get one chance to do the needle part. So you want to make sure that it works. Yes, articaine will last longer. Yes, they'll be more profoundly numb, but that might actually work in your favor. So if I had to do a stainless steel crown 74 and 75, I would give an articaine infiltration. There you go, articaine. bee's knees. We've got Carly here. What matrix bands do you typically use for interproximal restorations?
I just use a bulk standard Toffler matrix band, and I put a wedge in, and that seems to work.
Easy. We've got Hannah here. Is composite resin a better suit for baby teeth than Fuji materials?
So, as I mentioned, it really just depends on what you're trying to achieve. So, if you have an occlusal restoration, you can pretty much use anything. However, if you have a proximal restoration, yes, the recommendation is for resin over Fuji, definitely over a conventional Fuji, like a GIC, conventional GIC, so like a Fuji 9. Yeah. So, composite's going to be better than Fuji 9. Composite can be comparable to a resin modified GIC like Fuji 2, but the studies show that composite is better than a resin modified GIC. It's a little bit more durable, but you have to have good moisture control.
Definitely agree. Like anything with direct, you'd need that good moisture control. So getting rubber dam placement would be vital for that. We've got Dr. Han Nguyen. What are your recommendations to avoid disrupting the eruption of the sixes while placing an SSC on an E?
That's a very good question. So you got to have no overhang. So yes, it definitely does happen, especially when you've placed a hall crown in, let's say, a 3 or 4 year old who has hypermin E's, and you've popped it on and you're like, fantastic, I got it on, this child's pain-free, but you've placed a crown that's too big. It's really important that you take a step back and that you get the right crown before you go and glue it on. So if you are doing a hall crown, as I said before, just try a couple of different sizes. Try one smaller than you think, because it might actually fit, and then you can work your way down. And then when you're doing a conventional crown prep, make sure that you slice the distal surface of that E. And then, as I said before, try a smaller crown. You can crimp crowns, which I didn't really go through. But yeah, you can use a crimper to make the distal surface a little bit more inward shaped. And then that should prevent it from preventing the six from erupting.
Thank you. We've got another question here from Celine. What material do you use if you had to go to a pulpotomy?
That's also a really good question. So the majority of the literature supports the use of MTA. Unfortunately, it is a costly material, but is also the most effective. So I use MTA pretty much exclusively. I do understand that not everyone might have access to MTA. So the other materials that are often used are ferric sulfate and also the name has escaped me because I never use it. Formicrezol. Yes, formicrezol. Formicrezol has been found to be cancer-inducing. It has never been found to be cancer-inducing in a human, but there is that cancer-inducing property to it. So it has definitely fallen out of vogue. Ferric sulfate works and it works well. The only trouble is that when you're using ferric sulfate, you are applying a hemostatic agent to a bleeding pulp. So you might actually stop that bleeding with the ferric sulfate. So the recommendation when using ferric sulfate is to actually make sure it stops bleeding before you put it on, because when you're using the ferric sulfate and you stop the bleeding with a hemostatic agent, you might actually be masking inflamed pulp.
Thank you so much for that detailed answer. I think we've got time for one more question here. The last one here. Why wouldn't you use Fuji 9 to cement a stainless steel crown?
Yeah, I know. Hopefully I haven't offended anyone with that. Look, any GIC is going to work. It's just thicker. So you're not really looking for like a thick cement when you're putting GIC. Also, Fuji 9 is going to set pretty quick. A luting cement like a Fuji Sem is going to give you more time. So it's not like you're going to stuff up the crown. Like, it'll still work. I just think that it would be easier to use other materials.
Lovely. Okay, one more question, if that's okay. We'll squeeze one in. Sure. Can you use Odona paste for a pulpotomy? This is from Shelley.
So short answer is no. Calcium hydroxide is not recommended for pulpotomy procedures.
Okay. I think we'll finish at that. Thank you for everyone who attended. We've had quite a number of you turn up, so we appreciate the support for Dr. Alyssa. So please keep an eye on your emails for the next one coming up. I think it's Dr. Raina Yang about direct restorative for OHTs and dentists. So again, thank you again, Alyssa, and we'll see you next time, everybody. Bye, y'all.